a while, and when I look back at the roster of things that we talked about, we have covered a lot of information, and it does almost makes a book if we actually took the time to generate it. But so here's the United States. So first of all, we have what's called the BMT-CTN, the Blood and Marrow Transplant Clinical Trial Network. It started 25 years ago. Um, what happened is the goal was with a mission statement to conduct to make the country work together to conduct, as you can see, scientific and meritorious multi-center trials efficiently with the goal of improving outcomes. But importantly, it won't work unless we provide an infrastructure to allow the trials to develop. So, whoop, oh, yeah. So, as far as an organizational structure, it's funded by our two branches of the NIH. It's two-thirds is funded by the Heart, Lung, Blood Institute, and one-third by the Cancer Institute. There's some um, support teams that get funded by the NIH, which is the Data Safety Monitoring Board, and also a protocol review committee, which is basically a protocol development committee with high-end statistical support. They report to the steering committee. So there are 24 centers that are funded um, to be on to have a chair at the steering committee, and they've identified a strategy where there's some administrative committees, there's technical committees, as well as whenever a new idea comes up, it's voted on by the steering committee, and the protocol team will decide whether or not to move forth. And if that is given approval for team development, a trial a trial writing committee put together writes the trial, and then you have the data coordinating center, which facilitates its you know it's being written, being certified, approved, and being disseminated. And there are the 20 high performing centers, but there's also affiliate centers that are across the country that may be smaller, that don't necessarily have a vote on the steering committee. But over the years, it's now basically, it used to be a very select committee 15 years ago. Now it's become very open, and all transplant centers are invited to, at least participate. So there has to be a data coordinating center. It's actually shared um, it's help funded by the NIH, but it's shared between the leadership team of the statistical team at this CIBMTR, the Center for International Blood and Marrow Transplant Research. EMIS is a CRO that basically has the contract for the BMT-CTN. They're based in Washington, D.C. And then the National Marrow Donor Program, does funds additional provides additional funds on focusing on patient advocacy, contracting for individual trials of interest. And so the three of them help support. And the goal here, when you look at it, is identify the right patient population, definitely have strong scientific rationale, identify whether you can afford it. There's some great trials that could be done, but when you look at the expense, they may not be feasible. And so ultimately, feasibility is critical. So there's a lot of things you can do, but understanding what's actionable and what's not actionable. And so the foundation, they basically, in the world of committees, there's a series of committees of how they function. And I can tell you, one of the most important my important thing is every year we get held to accountability. We have a report card of, are we performing above expectation, at expectation, or below expectation. I'm proud to say the last 5 years, we were um, above expectation. We were in the top three, you know, sessions, and that comes into data accrual, how fast you can open a trial, how accurate your data are, how reproducibly you collect specimens that need to go into the biorepository. You get scored in all those things, as well as for all the different conference calls, what percent attendance do you take place? And so we currently are the OHSU consortium. We are one of the 20 funded grants. Originally, it started with Case Western, and the original 3 sites were back in 2001 was Case, OHSU, and University of Illinois at Chicago. We added some centers over the years that ultimately they joined us, but they basically became organized and became their own. They have their own seats at the steering committee. And so presently, the Oregon Consortium includes OHSU, Case Western, and Cleveland Clinic, Loyola in Chicago, and our newest member is the Sarah Cannon Research Center. There's 5 programs that do transplant and cell therapy, and together they do about 1,500 transplants a year. They're actually a for-profit funded by the Hospital Corporations of America. Sarah Cannon is a research arm of HCA, and they're part of our team. So with that background, I just think it's important to know what the BMT-CTN is and how it was generated. It did take work, and it did take people to get together and sit down in back 25 years ago to say, am I really willing to work with you? Is Boston going to work with Seattle? Are both of them going to work with Houston and New York City? You know, because no, all those centers were always saying, well, we don't need anybody else. We're big enough. But the goal was to bring it together. So where are we with non-malignant disease? So currently there is a brand new trial, or it's 3 years, started in 2022, which is the Cure Aplastic Anemia, the clinical trial for upfront transplantation to restore normal hematopoiesis. And it's a phase 2 trial, multi-center, using non-myeloablative conditioning, but also partially mismatched or partially matched or haplo transplant or unrelated, but not for relapsed aplastic anemia, but for new diagnosis patients. Where it comes from is about 10 years ago, the CTN launched 1502, which was the first haploidentical study for relapse refractory um, severe aplastic anemia. It actually included, patients not stopping at age 50 or age 60 or age 40, whatever your age limit is. But they said, we're going to take patients up to age 75. And they had a conditioning regimen of rabbit ATG, fludarabine, Cytoxan, 1 dose of TBI. And it was only bone marrow, but then it had the standard, a lower dose of filgrastim, given as to assist count recovery, but also your GVHD prophylaxis was post-transplant cyclophosphamide, MMF, and tacrolimus. But recognizing that the rabbit ATG that was given on day 9 through day 7 would still be present early on after transplant, it would be given contributing to a treatment benefit. Well, the results were published in 2022 in Lancet Hematology. And the 1 year estimated survival, this is for patients with aplastic anemia who had already failed immune suppressive therapy, who had already and were old. They weren't young. They were in patients as like I said, as high as age 75 were included, but it showed that there's an 80% 1 year survival. And when you look at the risk of acute and chronic GVHD, the risk of acute GVHD in this mismatched setting was 15% and 25% for chronic GVHD. Because we know that the big thing about aplastic anemia is, the biggest risk to the patient is GVHD. They don't have a disease they have to worry about relapsing. We just have to establish engraftment. So what they've chosen to do then is say, we're going to move the paradigm earlier. We're going to look for brand new diagnosis of severe aplastic anemia, and there will be a stratification based on young patients who have HLA-matched siblings or older patients who don't have, this is, sorry. Yeah, this is recognize that older patients normally would get immune suppressive therapy, of which 70% are response, but they would relapse. But if they didn't respond, they'd go to haploidentical. So this is how we approach. In the United States, young patients with a matched sibling go to transplant. Everybody else, you know, goes to immune suppressive therapy, and they only go to transplant if they have failure. So that's the goal here is why are we waiting to transplant? And so what the goal, yeah, you can see here is let's move it up. And so the trial that's currently out there that's planned will be the same regimen of 1502, which is uh, fludarabine, Cytoxan, ATG, single fraction TBI, and PT and post-transplant Cy. The dose of radiation though is increased to 400 centigrade, not 200 centigrade. Donors will be haploidentical related. The goal is to look at GVHD-free, failure-free survival because that should equate to a high cure rate. Um, and they want to evaluate haplo and unrelated donor cohorts. So this is the study. This does include kids, patients age 3 to 75. They have the diagnosis, and it's new diagnosis, no prior treatment, and they'll get, um, you know, they have to meet the definition of aplastic anemia. They will not have HLA matched donors because that would be a standard of care, but they're looking for people who are going to go to alternate donor. Performance status has to be over 60% KPS. And so the highlights here is this is going to be the first haplo unrelated donor where we're looking for upfront treatment. If they haven't really had a lot of transfusions, there should probably be very low risk of HLA antibodies. And so no prior desensitization will be needed, but we'll collect titers. And they want to remind everybody, though, there is a fraction of aplastic anemia that presents with or hypoplastic myelodysplasia can present as aplastic anemia. And so exclusion will be these patients. If people have aplasia or bone marrow aplasia with these abnormalities, they'll be excluded. If these are identified as a cytogenetic abnormality, they may still be permitted to participate. And so that's first non-malignant disease. The second non-malignant disease that's under study in the United States is multiple sclerosis. And there have been multiple randomized phase 2 trials compared to best available therapy, um, showing that that transplantation has improved 5-year progression-free survival and also 5-year MRI um, free, MRI plaque-free survival. There's one study from Canada that was randomized that showed at 5 years, it's over 80% of patients will have no evidence of an MRI change over 5 years after autologous transplant, and but there's over 90% likelihood of remaining clinically intact without progression of multiple sclerosis. So these are all, and other countries have become standard of care. Italy, I think, has led the charge for multiple sclerosis transplant. England is very active. But the United States has been held back partly from insurance and the lack of a phase 3 trial. So what they've done is identify a randomized trial, we find patients, it is specifically for relapsing, remitting multiple sclerosis. These are the patients that are very inflammatory. It's not secondary progressive where it's often a burnt out scarring condition. So they're looking for inflammatory multiple sclerosis. And so patients will then be identified by neurologists first as someone who's either had been on a primary therapy and it looks like they're now progressing. And so what they want to do is say, okay, they got to go to second line therapy or maybe third line therapy. So they see a neurologist and they get screened. If it looks like they have relapsing remitting multiple sclerosis and they would otherwise be eligible, they then come to a transplanter to be screened for their eligibility for transplant. And then they are randomized they're randomized to best available therapy that could start immediately, or if they're randomized to the transplant arm, what they do is they get a dose of Cytoxin with ATG, which is used to, in a way, as chemomobilization of peripheral blood stem cells. And the Cytoxin and the ATG will deplete T cells in that product that gets collected. And then they get their, you know, transplant administered with ATG. And the cells are infused on day 0 and then they're followed. And the goal is we're looking for the endpoint is a 3-year multiple sclerosis relapse-free survival. So the overview is shown here. This is your mobilization is Cytoxin at 4 gram per meter squared with Dex. I'm sorry, yeah, Dex, not ATG at this point. Sorry, Cytoxin and ATG. They get collected. Their counts drop, and on recovery, they get collected. Then they go into beam. They get myeloablative beam conditioning with rapid ATG. Then immediately they get their transplant. From day 7 to 21, when you have engraftment, they actually get put on low-dose prednisone because there have been some patients with multiple sclerosis. As they engraft, they become inflammatory. You know, the engraftment syndrome that we can sometimes see with autologous transplant. Well, if you have engraftment syndrome in a multiple sclerosis patients, you can create an autoimmune flare. So the prednisone is given for 2 weeks and then tapered over the next 2 more weeks just to diminish the risk of a MS flare. So there's 22 sites open. The goal was 110. You know, we're over 3/4 of the way there, and it's anticipated that in a year that they'll have the last patient enrolled. Now, what's been our experience? Well, it's been very interesting. I've had a patient with two patients enrolled who were on the best available therapy. They both have recurred. Now, the problem with the trial is it doesn't have a crossover. So if you're on the trial, you get the transplant gets paid for. If you're randomized to transplant, it's paid for by the NIH. If you're on best available therapy, and then your disease progresses, well, you want to get a transplant. Well, one patient was able to get a standard of care transplant. The other patient, though, um, when they develop Medicare disability, they no longer they Medicare has never identified that multiple sclerosis is a diagnosis for which transplant's given. So I've had patients who developed, who were on this best available arm, developed a relapse, but they couldn't get to transplant because there's no insurance for it, and they have to pay out of pocket. So we've done other things to get their disease under control, and potentially they may go out of country for a transplant, or maybe this study will be ended when they next progress. The other is it's a pretty intensive immune suppressive regimen between the Cytoxin and the mobilization, and then the ATG with beam. And we have a patient um, who looks great, who's done well. MS is under control. She's actually walking without a walker. Um, she can ambulate. She's made really marked clinical improvement, but now she's at 18 months out and still has marked T cell cytopenia. She actually came in with CMV disease because we were monitoring initially through day 100, but usually you stop monitoring then. Around day 180, she came in with a CMV PCR titer of over 10,000. We had to treat her CMV disease, got it under control, but even now she continues on letermovir a year and a half later. So we've learned something about managing a multiple sclerosis with autologous transplant, but it's a good study that's going to give an answer soon. Yeah, I could say in my own experience, none of our patients transplanted have progressed, while the patients with best available therapy have. So I have a feeling the study's going to be a positive. Whoops, uh-oh, didn't mean to do that. Let's get back to sharing. Sorry, I meant to go next slide. Come on, next slide. Where's my next slide? Okay. Do you see that, guys? Everyone on it? Still there? Hello?
Yeah, Prof.
Okay, just double checking if it was still going through. All right, so the next is talk about a little bit about lymphoma. So to show where we are with lymphoma. Now I talked before about this trial, I think in October, when this is a CAR T trial, and it's for patients who have relapse refractory large B cell lymphoma, either in second line or third line. We are going to, they're going to be candidates for commercial CAR T. So we register them they um, before they begin their lymphodepleting chemotherapy. So we identify a patient, we go to get commercial CAR T, we give them but right before they get registered with before the lymphodepleting chemo, they get their lymphodepleting chemotherapy and then they get their CAR. Now there's a lot of staging, disease staging that happens during that registration phase. It's been important because on day 30, they get restaged. That can include a bone marrow. If they had disease with the bone marrow before, it definitely includes a PET scan, of which we use Lugano criteria. And then they're evaluated. If the patient has progressive disease at day 30, they're off study and you can do what you want with them. If they're in complete remission, well, we know that patients in complete remission may be cured. So they also are just observed longitudinally. Um, there's some blood marker and biomarker draws per protocol, but they're left alone. But however, if they are stable or a partial response, so in between, we still see shadows, and we see that at day 30, because sometimes the CAR can continue to, function over time. But then they're randomized as a four-arm randomization of bispecific antibody, immune conjugate CD79A, a combination of the bispecific antibody and the immune conjugate, or recognizing that up to 50% of patients with a PR go on to CR observation. This study also is accruing well and hopefully will give some important information about the management of second line and third line CAR. Yeah, and the prediction is, in this population of progressive disease and I'm sorry, in this population of stable disease and partial response, at 1 year PFS is 25%, and it's felt that perhaps we can increase that to 50%, and that's the statistical arm. If the patients do go on the observation arm and they progress, they can then cross over. And I actually have a patient who was on this study who got randomized to observation. He crossed, so he did relapse around day 120. He's now finishing the cross 6 months of Mosin and Pola. So primary objectives is look at the 1 year progression-free survival for stable disease or PR patients with the goal that in comparing it to consolidation therapy versus no consolidation therapy. It'll be interesting to see if one of the consolidation arms proves to be beneficial. Well, maybe we may need a one-on-one, to figure out. And it's then there's a whole series of secondary objectives of which overall survival is most important. Now, another lymphoma trial is for peripheral T-cell lymphoma. Now, this has been a question that's been asked in transplant for years. I actually went back 30 years ago to SWOG 9703, which was this trial that looked at, auto transplant and CR1 for high grade lymphoma. Most of those were B cell lymphoma patients. There was an advantage to transplant if you had, high grade lymphoma. But there was a small number of T cell lymphomas on that trial. And in that trial, early transplant or no transplant for consolidation, there was no difference. So this is a question that remains. So what do we know? We know that transplanting PTCL in CR1 remains controversial. PTCL does have a high risk for relapse. If we look at B cell lymphoma treated with R-CHOP, we expect 60 to 70% of patients to have long-term progression-free. If a patient with peripheral T cell lymphoma gets a CHOP or CHOP variant, we expect at best a 30% long-term progression-free survival. Thus, auto transplant is often offered to these patients, but it's never been really tested in a randomized controlled study. And so they're trying to do that now. I will also say, as I say this, I would believe it's France started a similar study a year ahead of the BMT-CTN. So they may actually have an answer first. It might be Germany, but I think it's France, but we're watching for that. So I will point out that there has been an interesting first line approach. If you identify poor risk peripheral T cell lymphoma, they identified there's a randomized trial of auto versus allo for first line. And this was going to be, again, these are like things like NKT lymphoma, gamma delta lymphoma, some of the higher risk groups. And what was shown is if you have the likelihood in this particular randomized trial, relapse was much higher in an auto transplant, 40% relapse at 3 years, no relapses in the allo arm. Graft versus lymphoma is there. If we look at non-relapse mortality, though, the non-relapse mortality in the allo setting was around 30%, when in the auto setting it was 5%. So when you look at overall survival statistically, there is no statistically significant difference of allo or auto in first remission. So the conclusions of this trial is you can do auto if you wish. You could do allo if you wish, but allo is probably um, best saved for those very, very high risk patients or for patients who relapse after auto. And again, these were poor risk um, peripheral T cell lymphoma. So now the new study is taking any peripheral T cell lymphoma other than ALK positive. So ALK positive is just has a high cure rate alone. You leave that alone. But so ALK negative angioimmunoblastic, nodal PTCL or peripheral T cell lymphoma not otherwise specified, which is recognized as probably about 85% of all peripheral T cell lymphoma. They're stratified by disease and then which chemo they're getting for induction, because people will get variants, but they will then be either get induction chemo with etoposide like CHOP, they'll get brentuximab, or they'll get CHOP. They'll get randomized into observation versus autologous transplant with beam conditioning. So it's probably a study that was obvious to be done years ago. It never got done because everyone said, you know what, there's other more pressing issues. It's finally being addressed in the United States and in Europe. So again, the goal here is to demonstrate improvement in progression-free survival in the transplant arm versus the observation, with secondary to see if there's a difference in overall survival. Interestingly, they're going to try and look at MRD. That's being introduced as an exploratory objectives. It's hard to, how are they doing it? Maybe T cell receptor gene rearrangements, but to look at the impact on whether transplant makes a difference to clean up. Because remember, these patients should be in like disease control before they're randomized. And so the goal here is to improve the 3-year progression-free survival by 16%. So for progression-free is 42% at 3 years with observation, or 47 to go to 63%. Cure should also be present, but lower than the observed long-term. So we'll see where this takes us. This was interesting. I was unaware of this study, is because I don't pay that much attention to Hodgkin's. I just don't see that many Hodgkin's. I get them. I see a Hodgkin's. I take them to auto transplant. But there's actually a study sponsored by ECOG and endorsed by the BMT-CTN looking at Hodgkin lymphoma. Scheme is if you have relapsed Hodgkin lymphoma, you get a salvage therapy, and you have a choice of options. It could be brentuximab, nivolumab, pembro with GVD, brentuximab, bendamustine, or standard classical ICE therapy. You get a PET scan, and if you're in a complete or partial response, You then basically you're identified then as standard risk or high risk, and you're going to be randomized to an experimental arm, an experimental arm, but both ultimately going to be transplants. So it's you're diagnosed with relapse, you get treated to CR or PR, and then based on your presentation, were you high risk or standard risk mild Hodgkin's, you're then randomized again to either conventional chemo or transplant. Um, Asking the question is, does transplant still have a role in Hodgkin's? Is as we now have new biologic agents. So the current standard at first relapse is often salvage and high dose transplant. Now, in this current age, checkpoint inhibitors are very commonly offered. Obviously, checkpoint inhibitors weren't offered before 2020, probably mostly. And we know that they said low risk patients um, have had good outcomes by getting checkpoint inhibitors without needing a transplant. That was been published or in an abstract form, and so that's what's going to be tested. What's the definition of the high risk group? Is you get primary refractory disease, where you within 3 months of completing a frontline induction regimen, whether it's if it's ABVD or whichever regimen you use. If it's chemo based, it's an early relapse. If it's a checkpoint inhibitor based, it's relapse within 6 months. Also, more than 4 disease sites at relapse. This is your definition of high risk. Everything else is standard risk. And they want to point out is if you look at high risk versus standard risk, I'm sorry, if you look at refractory disease versus late relapse, because again, refractory disease, those early relapses tend to be more aggressive. You could see this is the refractory group who get transplanted. The refractory group, you know, have only a 40% long term, while those that have late relapse have closer to a 60% long term. So that's why they're paying attention to this, these issues here, asking the question about checkpoint inhibitors here, to asking, the checkpoint inhibitors there. So standard risk has this model with a goal of improving 2-year progress standard care be um, predicted at 2-year protection-free survival of 72%, and the experimental arm um, standard cares with transplant, with getting post-transplant brentuximab, and they're saying the 2-year progress, the experimental arm may be 68%, but ultimately um, it takes 270 patients. We're looking for a small number difference, so it is a large number we're taking. High risk says that we're trying to increase the likelihood of progression-free survival to 50%. The null hypothesis is going to be the same as standard of care, but alternately, if we're more aggressive with using transplant and pembro and brentuximab, we can improve that to 65%. This particular arm is going to be 100 patients. So it's a lot of patients. It's going to take the whole national effort to get this. I don't know. Honestly, this is the kind of study I think may not accrue, but we'll see. Briefly, AML. There's only one current national trial that's active, and this is based on whether or not venetoclax is introduced into conditioning, and whether on with or without venetoclax maintenance can improve outcomes of AML in first remission. So this is a paper published by Jackie Garcia from the Dana-Farber Cancer Institute, which looked at transplants of patients with high-risk MDS and AML. Many of these patients had active disease at the time of transplant. So you could see if you look at flow positive disease, um, here is in red. Most of these patients, prior to transplant, were active disease. Only a few patients were negative. They basically this is by flow, and next gen sequencing is showing a little more sensitive. There were a number of patients with active disease, Here's your TP53s in orange. You can see in the lower curve is, we see a lot of P53 AML. So they all received a reduced intensity transplant of a little low dose busulfan with fludarabine and venetoclax given um, during induction and also after transplant. They got a combination of azacitidine and venetoclax, and you can see that this is 2 years out. There's a significant number of patients that are remaining free of disease. We know in allo transplant, if you get to 2 years, we expect a 90% long-term cure rate. So there were early deaths. A lot of them were P53, but after that, you know, in a high-risk patient population, looks very promising. So the hypothesis is maybe that the venetoclax does make a difference, and so I could tell you the original trial was designed as venetoclax with azacitidine, but there's a trial also study called VILT, which was using maintenance azacitidine versus placebo in the post-transplant setting. That study was published last year and was a negative study. So the company has closed all azacitidine maintenance trials. So the trial was reformulated as a transplant eligible patient for patients in CR1 for patients who have where they'll introduce venetoclax. And nationwide, you should know that, or you could know, or you should know in the United States, it's taken over 5 years to do this. But now, even in community centers, if there's a patient diagnosed with AML, they can have bone marrow or peripheral blood sent to be registered in a molecular pool, which they call MyeloMatch. They then there's tier one trials or induction. Tier two is persistent disease. Tier three is transplant, and tier four is refractory after transplant. But there's 4 levels of trials being developed for the MyeloMatch schedule. Well, the trial I'm going to show you is the first tier three transplant study. And so what it is going to be a randomized trial of adults who are getting either matched sibling or unrelated transplant who are age 40 to 75. And they will be randomized. There's double randomization. They can get Buflu or Flumel induction with venetoclax or with placebo. So you could choose your conditioning, whichever you want to do, but venetoclax up front versus placebo. You do the transplant, and then somewhere around day 100, after a bone marrow biopsy, if they're in remission, they then get again randomized to maintenance versus venetoclax, and with 2 cohorts. With patients who are MRD negative, they have to be MRD negative, and they're followed. Again, here's the placebo group who never saw early venetoclax. They're randomized to venetoclax or placebo, or in this case, they got venetoclax. They're randomized to venetoclax or placebo. So there's going to be 4 subgroups, basically, and then they're going to be followed for a year, looking for MRD-based outcomes as well as death. Eligibility, as you can, is what I just told you. Exclusion criteria: if you had been induced with venetoclax and you clearly refractory and you had to be salvaged, let's say with chemotherapy, then those patients would not be eligible. Um, Prophylactic or preemptive DLI wouldn't be eligible, or patients who have prior viral infections, they're eligible if you meet criteria. Basically, you have to be treated for the viral infection and be viral PCR negative at the time. So it's 5:45, almost 5:43. I'm going to stop for a second and see if there's any questions, because we could also divide this, because I have 2 more sections. One is GVHD and one is transplant. One is myeloma. So any questions from folks?
Thank you, Prof.
Hello, Richard.
Yes.
For venetoclax maintenance, when do you start?
Well, they're starting in that trial at day 100.
Day 100.
Day 100. Now, there's other studies that have said for FLT3 inhibitors, for FLT3 positive disease, We know that there's a significant number of relapses by day 100. So a lot of those studies, the ones that we did gilteritinib, the one that did sorafenib, the study I ran with midostaurin, we started often as at day 42 to day 50.
Okay, and you give the maintenance for the every how many days for this
So
maintenance cycle?
for this trial, it was for one. I believe it's for 1 year maintenance.
Every day?
Um, every day.
Oh,
Yeah.
so we have maybe 3 4 patients who receive the venetoclax maintenance.
Yep.
Up, but not after transplant. I mean the after CI after chemotherapy, and they just didn't want to do transplant, so we give a venetoclax,
Yep.
just only 1 or 2 tablets
For how
for
long do
about.
you continue?
No, I give only a week,
A
a
week.
week
Yeah.
every 6 to 8 weeks.
Well, I will go back and check, but you can look at this. This is the figure from the presentation. It sure looks like it's a daily. It says daily, and we know in
Uh-huh.
myeloma we can use venetoclax daily. Um,
Uh,
so whether it's this should be a healthy bone marrow that's reconstituted, and maybe
yeah.
it could take the insult. But I can
Yes.
double check with the study and make sure that it really is daily or if it's pulse. But I believe it's a
Yeah.
daily treatment.
Good. Okay. Thank you.
Yeah, and then the big question in here, you can see it stops at 1 year. The the sorafenib study and the gilteritinib study, you know, extended for 2 years on maintenance on those formal studies for the patients that were considered eligible. I used to point out though that at 1 year, 80% of patients should be cured. At 2 years, 90% of patients should be cured if you look statistically. If we look at the
Yes.
cost, I don't know the cost in Thailand, but I know the cost of sorafenib and gilteritinib in the United States. If an extra year of sorafenib adds about between 250 and $300,000 of expense, and the extra year of gilteritinib is over $350,000.
Mm-hmm.
When you just look at the price. So I'm just saying those maintenance is expensive. And this study here, again, I'm not saying that this should be done. I'm just saying this is the study that's being sponsored in the United
Mm-hmm.
States. It would
Yeah.
be if it comes up positive, it would be a very expensive study.
Yes. Mm. Thank you.
Thank you, Prof. Any question from Dr. Nutra or
And
Payathai too?
yeah, I just have a little bit question with how long do you give the venetoclax post transplant? How long do
How
you prepare to stop?
say that again? How long when?
How long do you give the venetoclax post transplant?
Oh, before transplant?
After.
After transplant, I don't give venetoclax unless it's on study.
Ah,
So
is that
so I mean, there's some patients. If you have some people have adopted this venetoclax maintenance strategy,
uh-huh.
you know, based on this paper, Jackie Garcia's paper, where they use a venetoclax maintenance but it's early on they use it, and but nobody knows how to do it. It's very empiric. It's a lot of small studies, small institutional practices. That's why it was felt important across the US to answer the question, does venetoclax actually should be used? In a way, that's what happened with azacitidine. There was a preliminary data that azacitidine in phase 2 trials was beneficial. And so people did 6 months of
Before.
azacitidine for maintenance. Now the trial shows that there is no benefit to azacitidine. Azacitidine is now not used. Some people, if you have a P53 or a complex karyotype, they will now introduce, go back to decitabine, like 5 days of decitabine, at 15 milligram per meter squared every 6 weeks for 6 cycles. But that's based on a study from Washington University in St. Louis. But again, there's really no large randomized trials still proving that maintenance does anything. We may be treating ourselves and not treating the patient. The main cure comes from the allogeneic graft versus leukemia effect, and not from you know not from what we're doing here.
Richard,
Thank you.
Richard,
Yes.
Richard, should we use MRD monitoring to give venetoclax maintenance? If
Well, that's
MRD is negative, we should not give any maintenance. But
well,
if
actually,
MRD, yeah,
this is exactly where people are developing. They want to develop MRD driven strategies. You can see this is a trial that everybody's going to get everything, but you can also see by stratification, they're going to look at patients who are MRD positive or negative, and they're going to measure events of persistence or relapse versus morphologic relapse. They're hoping to get from this trial the data that would support that premise. These are the questions that you are asking the right question. You're asking the question that everybody's asking. It's just that it's still, I feel I should do it if someone's MRD, if they were MRD negative and now they're MRD positive, what can I do? I can rapidly withdraw immune suppression. Like I can cut down their immune suppression faster than I was before. I can give a drug like decitabine. I can give a drug like venetoclax. I can give a combination. I can do dose, I can give DLI. So people are doing all those things, but there's no prospective studies in the United States that tells us that this is what you should do or what you shouldn't do. There's a very nice series of studies from Germany that were looking and testing using CD. They were collecting after bone marrow. They were looking at CD34 chimerism, and so if you had, we do chimerism studies, we still see some host material, and that could be a non-important cell. But if you did a CD34 chimerism and you still see host CD34 chimerism, relapse rate is very great. And so in that setting, they did a set of series of studies of the donor leukocyte infusions, and they had clinical improvement, but again, not ever done in a randomized setting. So not ever done to the point that people, I'm going to stop here after all. That people are convinced that it made a difference in the outcome of patients. So for all the number of patients that get transplanted with myeloid malignancy, we still don't know. We have so many answers that we don't have. And a lot of it's because, by the way, what is MRD? Honestly, I was on a national call in November, which was trying to identify whether the international registry, the CIBMTR, should start collecting MRD data in AML. We know they collect it in ALL because we have clone-seq and we have very reproducible data of what level of persistent immune globulin rearrangement from the tumor is predictive of relapse. I could tell you this was a 4-hour conference call, and the decision was at this point, we don't know enough about MRD to introduce it as a risk feature in the IBMTR. And so why is that? Well, we have a next generation sequencing panel that looks at 200 different genes. Well, how many of them are important? How many of them are silent? How many of them are just chip that aren't going to do anything? How many are really pathogenic? And I think Chris Horrigan, who was at the NIH and published some beautiful paper on deep next generation sequencing, he's proposed that you can actually have a panel of, I think it's 12 genes only, that you don't need the rest of it, but study those 12 genes in an organized fashion and study that longitudinally. So Chris Horrigan is a consultant on this study I just showed you. The MRD question remains, but it was finally decided that we do not know which, besides FLT3 and maybe NPM, we do not know what MRD signal means anything at all. What's actionable, what you should do, and so it remains under study, and that's why this study and future studies are going to start to collect the MRD data in a central laboratory, not at like we do our own next gen sequencing. The Fred Hutch does flow cytometry. MD Anderson does flow cytometry. Moffitt in Florida does next gen sequencing. And we all say our assay is better than yours, but they've never been tested prospectively. And so we're trying, that's also being done, that there will be a central laboratory for the MRD testing to answer that, hopefully answer these questions going forth. So that's a long-winded answer to tell you that we now have tools, but we don't know how to use them. And so we all have our opinion of what we should do with that tool. I do believe that if we have someone who's clearly MRD negative and becomes MRD positive, I think that person is on the way to relapse and we should do something. For me, my number one is a more rapid withdrawal immune suppressive therapy rather than add something. But I do think that these are questions that I think the next decade, the next generation of myeloid transplanters are going to answer.
Good. Thank you.
So if this was, I don't know if this was, again, if this was interesting, I still have another section we can do another time where we have GVHD and we have the current status of myeloma trials. But I just thought this is relevant. This was part of the transplant meeting I just went to. We usually don't talk, we talk a lot of review of what has been shown, but we don't talk a lot about the future. And I thought that this might be interesting to you to see what are the questions being asked in the United States currently that we hope to answer in the next 5 years.
Yeah. Thank you. May I ask another question?
Yes, please.
In severe plastic anemia, I think the current treatment with immunosuppressive agent plus lomipostime or L-torvapax working very well. So, to my opinion, we should not do haplo transplant as first line. We should wait to get the response, to see the response to the standard immunosuppressive.
Well, that has been the standard of care. But what we know is if you do go to immune suppressive therapy, a lot of people respond. Third of the people don't. The ones that don't respond have to go to transplant. But the ones who do respond, half of them will still relapse their aplastic anemia in the future. So that's the background. And honest to God, we do the same. If I have an older patient with aplastic anemia, I will do one course of immune suppressive therapy. I used to do 90 days worth of immune suppressive therapy before thinking about transplant. Then based on that study from 2015, we started saying, okay, by day 45 or 50, if you're not showing a response, we're going to transplant you. But this is a new trial. And by the way, so this is testing upfront based on data. They're extrapolating a response saying that we can cure people. And we think it's going to be a better outcome. And, there's usually, remember in this case, there's no rush to get you. We're not trying to get the tacrolimus off by 6 months. We'll leave people on for 1 year or 2 years to make sure they're completely immune tolerant before stopping everything.
Good. Thank you.
But the important message of everything I said today, I think, is these are questions that are being asked. The answers are not there yet. And people are, and what's going to happen, it's either going to be the trial's going to fail to show an improvement, and then we're going to say, you know what, do immune suppressive therapy first with eltrombopag and ATG and cyclosporin, or it's going to say, you know what, that was a good idea, but we won't know until we get the answer.
Yeah.
Yeah, so this is not these are not standards yet, but these are questions at this point.
So Richard, I think this is very beneficial. So I suggest that you should have another session, as you said, on acute USD and myeloma.
All right, well, I can do that too. Like I said, this is, the next time I talk, we can do GVHD and myeloma, because I have, again, I put together the list of the trials. When I put these, I just put information out there because I want to share with you, and I just try to build. I build this to share, and I want to always create a dialogue. And like I said, I can definitely show, where we are with there's 2 new GVHD trials that are opening, and there's about 5 new myeloma trials that are opening, and I think it will be interesting to look at them.
And also, I